Our next speaker is Dr. Steineke. I'd like to introduce him. He is the Director of Pediatric Neurosurgery, the Director of Skull Base and Vascular Neurosurgery. Here he comes, and he's right here at the JFK Medical Center. So thank you, Dr. Steineke.
Good morning. How are you doing? All right. So I'm going to do this a little bit different style than you're probably used to seeing it. Ironically, the last time I was here and presented, I had one of those kind of strange accidents. My kids were running one way, my dog was running the other, and I chose to hit the wall and broke my foot. And that was just about 3 or 4 years ago. And about a week ago, I was actually had my Droid, my phone, on the ledge, and for somehow I got jiggled, and it came right down on my foot and almost broke my foot again. So I'm hobbling around again. So forgive me if I'm hobbling around. Something about this conference and my feet just don't get along. Okay, so just wanted to do a brief introduction. It's benign brain tumors, and I'm going to do a little bit different style, like I said. First of all, I'm going to do more of a conversational style. So if you have a question, feel free to interrupt me. Secondly, you're not going to see a lot of statistics. You're not going to see survival curves and that. It's going to be, I envision it more, I'm speaking to my patients. Yeah, it's back and forth, it's a conversation. It's going to be in a style that it's more patient-oriented. Hopefully will make a little bit more sense. And to be perfectly honest, to know that a chordoma arises from the primitive notochord, I'm not sure what that does for anybody. So you're not going to see a lot of that. Also, it's going to be inspired a bit by a talk by one of my professors at Johns Hopkins. All his talk was just pictures. Pictures, conversational style, answering questions on the fly. One of the best talks I had at Hopkins, and it turns out the guy did it because he was dyslexic. And so he just didn't do well with words. I'm not dyslexic, but I'm going to go along that venue. So that's kind of, also the type of tumors we're not going to talk about are the benign brain tumors and intrinsic tumors, the grade 1s essentially. You may have heard of JPAs or juvenile polycystic astrocytoma. It's a primary brain tumor. It's within the elements of the brain. My talk is focused more on the primary brain tumors that are outside of the brain, but still cause a lot of different issues. We'll be talking about pituitary tumors, chordomas, craniopharyngiomas, a little bit about acoustics or vestibular schwannomas, and we'll finish it up with meningiomas. I'll tell you basically what I see when patients come in, whether they're complaining about, what are the issues that they're dealing with at the time. We'll go a little bit into the tumor, what are the treatment options, how do we treat these, what do we do about them, and then the outcomes, how do the patients feel afterwards, what to expect, and then the quote-unquote, are we done yet? Now, with general principles of benign tumors is a lot like real estate, and somewhat similar to the primary brain tumors or the intrinsic tumors, is a lot depends on location. Where is the tumor located really is going to inform what symptoms a patient's going to come in and presenting and complaining of. Also, it's really going to affect how we're going to treat the patient and what to expect afterwards. The type of tumor definitely plays a role in what to expect, recurrence rate and the overall outcomes, and then what different treatment options. So to jump right into it, okay, the first category is the pituitary tumors, and I don't have a, all right, here we go. Okay, this is just a picture of what this area should look like. And so kind of seal it in your mind. So this is a normal pituitary, and what I'm talking about here is right through here. Okay? It's about the size of maybe a peanut, and it controls all the major hormonal functions of the body. Now, an important thing to realize, and it's going to predict what these things cause, is here is one of the optic nerves. The optic nerves go right over the pituitary. So they basically go from the eyes to the brain right over the pituitary. So it's easy to predict that if something is growing in this space it's going to push up and cause eye problems. So again, the whole principle of location, location, location. Also, it produces hormones, so you can imagine that's going to be one of the problems that patients present with as well. And those by and large are the two things that patients present with. This is a picture of pituitary tumor. Again, this is kind of that side view. It should be about a third the size it is here. This is a tumor that's pushing up into the brain. And you can imagine you're really not seeing that optic nerve going over it again because it's compressing it. Now on this view, this is to just kind of orient you. Again, you have the nose and the lips and then the back of the skull. Okay? So this is a side view. Imaging works that we look in slices. And so basically it's slicing from one side of the head to the other, and you're right in the middle here. The other image basically is slicing from the nose back in little slices. The ears are on either side, or here and here would be the ears. The nose would be in front, back of the head's in back. And so again, you have this mass, this white mass, and generally white things on MRI scan, it's not good. So if you see white on MRI scan, generally not good. Again, this is the optic chiasm and nerves. They should be located about here and flat. They've been pushed up. So how do these patients present? So one of the way they present is by compressive symptoms, visual loss, double vision, blurred vision, the classic loss of vision on the outside. Also, you can have the double vision, the nerves that control the eyes, control the movement of the eyes, essentially run right over here in what's called the cavernous sinus. If those nerves get affected, you start getting double vision. And that's a very common symptom of patients with pituitaries as well. Now, to go a little bit into the biology of the tumors, the pituitary gland is hormonal tissue, essentially. As you know, tumors basically arise from normal tissue. There's some genetic alteration. They become abnormal. They lose their sense of stop growing, and they continue, and they start growing. So the pituitary tumors are essentially hormone-producing cells. Now, we used to say non-secreting versus secreting, but they found that almost every pituitary secretes something. The question is that is it a functional something or not? And so that's how we split them up. We split them up into functional pituitary tumors versus non-functional pituitary tumors. The non-functional are kind of the ones that I just explained. They're going to present because of compressive symptoms, that's visual loss, double vision, or loss of hormones. A lot of patients will present, they'll be very tired because they've lost their thyroid hormone. Also, they can gain weight because they've lost the cortisol. So there's various hormone problems they can present with. But it's due to a lack of hormone, not hyper-produced hormone. The functional ones, those are the classic that overproduce hormones. The most common is a prolactinoma. Prolactin is a chemical in the body that basically gets the breast ready for nursing. So you can have enlargement of the breast, you can have galactorrhea, which is milk production in the breast. It can happen in men and women. Often women really don't notice this sign as quickly as men. When men start producing milk, it's more of a concern to them. And a lot of times women, they've just had a child, or they've had a child a couple of years ago, they get a little stimulation there, they just don't see it as a big symptom. Also, other symptoms of prolactinoma are loss of interest in sex, loss of libido. In men, it is erectile dysfunction, loss of ability to function. And a lot of men are embarrassed to admit that, and again, it delays, that's one thing that delays the men's diagnosis. That's the most common hormone producing. Unfortunately, there's a medication for it, and we'll get to that. That's one of the few benign tumors that we actually have a medication and we can avoid surgery usually with that medication. The other type of hormone producing one is Cushing's disease. Cushing's disease overproduces a hormone that stimulates cortisol production. Now, cortisol is a hormone that gets us ready in the morning to challenge the day. Basically, it's high in the morning, it gets us up, it wakes us up, it gets us ready to go in the day. It's one of the stress hormones. And so if you lack that, then you're often tired, you start gaining weight, you have a blasé attitude, can also be associated with some emotional issues, some depression. And so also it has a tendency to, so that's the hypo. The hyper has a tendency, again, it doesn't really get you excited. A hyperproduction of it starts causing physiological problems. If you've ever known people who have been on steroids for a long time for different disorders like rheumatoids, people, actually the brain tumor patients who are on the steroids for a long time, has a lot of the same similar symptoms of that. You start getting the swollen face, you're what's called the moon faces, you start gaining weight, you often get a buffalo hump. So all the bad things of steroids, that's what the Cushing's disease patients get. Their blood pressure can go up. So on a physiological level, it's a bad disease. Growth hormone is, as you can imagine, it produces growth. So if it occurs in a child who has not had gone through puberty, basically they grow tall. That's the giantism. I had a young man who was of Latino descent. His father, I think, was 5'7", uncle was about 5'8", and this kid was 6'6", and he was 14. And so they just thought he was going to be a big kid. Well, genetically having somebody, everybody else is 5'6", and you're 6'6", the genetics are not good for that. So his pediatrician, something clicked in his mind, this is not quite right. In fact, the kid had a growth hormone producing tumor. He didn't mind it because it made him a great basketball player, but ultimately I treated him, and he stayed at 6'6". He's happy with his height, but overall he won't have to deal with the hypertension and some of the other problems that growth hormones produce. And once you're over adolescence, then you start having the classic growing of the hands, growing of the feet, the nose and the facial features get real coarse, and it's called acromegaly. And often patients and not even families don't really even recognize it, but if you look at a photograph 5 years ago, there's generally a dramatic difference. And so those are the three most common functional tumors. A much rarer one is the hyperthyroidism that's caused by pituitary tumors. That's increase in the thyroid hormone. These patients have an increased blood pressure, increased heart rate. They're really kind of agitated a lot of the times, and they lose weight. Again, a rare one. I've seen it. I've treated probably 200 to 300 pituitary patients in the last 5 years. I've seen it maybe once, so it's a rare one. Okay, so we talked a little bit about the presentation. Now, patients with pituitary tumors often have headaches. The mechanism is not clear, and I joke around with my my patients that I generally create more headaches than I cure as a surgeon. So I can't promise taking the tumor out is actually going to treat the headaches. About 50 to 70% of the time it does, but I don't make that promise. It's probably a stretching. There's dura that's all over that covers the brain, and we'll get to that with the meningiomas. It's probably a stretching of this dura that causes the headaches. And so about 50% of the time, it does get better when it's treated. So headaches is very common. And this is not often talked about, but often these patients will have psychological issues. And I'm not meaning crazy. I'm meaning they have mood disturbances, are often depressed. A lot of times they don't get their diagnosis until several years down the road, so it's frustrating. They don't know what's wrong with them. They know something's wrong, just nobody nails it down. So there are some mood disorders that go with it, some anxiety and that go hand in hand with it. And my theory is even, the hormone system in our bodies are so complex, and it really ties into our emotional systems in the brain. So even though the hormones may not be that bad, it doesn't necessarily mean you're not going to have a reaction to it, and it can be a stress reaction. So, okay, so what do we do about it? By and large, let's actually get back to this. By and large, there's basically three things you can do about benign tumors. Pituitary tumors are no different. Now, if this tumor, instead of being this big, made the pituitary maybe twice the size, maybe it's about half the size, It would be called a microadenoma. Microadenomas are common. If you scan 100 people, you'll probably find 4 or 5 have them. They don't even know about it. The microadenomas that are functional, we usually will present with symptoms, the growth hormone, the Cushing's, and that. And those typically we will recommend treatment for. The microadenomas that are non-functional, they're basically sitting there. We don't know how long they've been there. And if they're not causing symptoms, a lot of patient will fall down, hit their head, they get a scan, the pituitary looks a little enlarged. They get an MRI scan, lo and behold, they have a microadenoma. All right, so what do you do about it then? Most of the time, if they're small, they're not causing compression, and they're not causing hormone abnormality, you watch it. You rescan in 3 months. I usually rescan in 3 months, 6 months, a year, and then do yearly for a while. If there's no growth, typically you don't need treatment. If there is growth, then that's the time you have to think about treatment. The mainstay of pituitary treatment is surgery, with the only caveat is the prolactin level. Now, if it's a prolactinoma, there are medications, for instance, bromocriptine, in which do a very effective job at treating these tumors. Often they shrink. Sometimes they completely go away with this type of treatment. And probably about 50 to 75% of patients with a prolactinoma can get away with just medical treatment. We do watch those patients, so sometimes patients simply can't tolerate the different medications and cause headaches and cause GI symptoms. They come to me and they say, please, just take the thing out. I don't want to deal with the medications anymore. And then if it grows, sometimes these medications won't be effective. Maybe in 25%, the tumor is going to grow through it anyway. And that's the time to think about treatment. Now, and it's not that I'm just a surgeon, so everything like the carpenter who sees a nail and everything looks like a nail. Surgery truly is, in my opinion, the mainstay of treatment for pituitary tumors. The reason is that, and the treatment types are surgery versus radiation treatment or gamma knife. Surgery is minimally invasive. We basically go through this route. It's called an endonasal approach. Sometimes we use a microscope, sometimes we use the endoscopes. And we open up a window in the sinus here. Actually, we open up a window in the sinus, and you're looking right at the pituitary gland. So it's minimally invasive. It's a 2 to 3 hour operation, and the overall risks are quite low. It's 1% chance, much less than 1% chance of any major morbidity, maybe a 1% chance of infection, and maybe a 5% chance of a worsening pituitary problem. Alternatively, radiation is used. There's a couple approaches. One is gamma knife, and I'm sure gamma knife, maybe you don't know much about gamma knife, given it's the focus of this conference. Gamma knife is a very focused type of radiation. It's a one-time shot. It's almost like when you're using a magnifying glass with the sun, how it focuses the sun's rays down, it really becomes hot. That's what gamma knife does. So it basically focuses radiation to one point through many different points, and that makes it very hot where you're focused, but every other point, it's not hot. So very effective treatment when we start talking about the other types of tumors. The problem with pituitary tumors is the optic nerve is riding right over top of it. And if the optic nerve is close, the gamma knife is going to cause visual loss and visual problems. Also, the hormone problems are almost guaranteed with any type of radiation. So you're going to have almost guaranteed worsening hormone problems. So surgery really is the mainstay if you need treatment. In my opinion, it's usually, if it's prolactinoma, medication, and some people, and we'll probably get this in the question, I won't go into it right now, some people will use the prolactinoma treatments for other pituitary tumors, generally not effective. Some patients really want to go a medical route. We try that for a while, but I haven't seen it be effective for anything about the prolactinomas. All right. And so what to expect afterwards? Surgery, like I said, is a 2 to 3 hour operation, typically in the hospital 2, 3, 4 days. Home, usually within a month to 6 weeks, you're back to feeling yourself again. Your energy level's back, you're feeling pretty good, you're back to regular life. Again, the radiation and gamma knife, I usually only recommend those to patients who cannot tolerate surgery. If you're 85 and you have a lot of medical problems, surgery is going to be overly risky for you, but the tumor keeps growing, we have to do something. And so that's the general what to expect after the operation. And again, the hormone problems can persist. I tell patients if you come in with a hormone problem, there's maybe a 50-50 chance that that's going to reverse itself. So whatever you come in with, you usually leave with the large tumors. Okay? Unless it's the caveat's hyper-producing the functional ones, the whole goal of surgery is to remove the tumor and get rid of the hormone excess. All right, so that is pituitary tumors, and keep this slide in mind for the next two type of tumors. That's the general approach. That is how we take them out. The next is what's called a craniopharyngioma. Now, these are tumors that are in the sellar region, the pituitary region. You might recognize this from the previous slide, but this is essentially where the pituitary lives. Okay? Craniopharyngiomas live in that area, but they don't play by the rules. They start growing up into the brain, and often they cause compression of the brain symptoms as they're presenting symptoms. These patients are typically younger. A lot of children and young adults are affected by the craniopharyngiomas. And to slip a little bit of science in on you, it's during development there's a duct that forms in the pituitary. It's called the craniopharyngeal duct. Essentially, it's a remnant of that duct that these tumors grow into, and so you can predictably it's going to cause pituitary problems. Typically, these patients are pan-hypopit. I just saw a young man who is 22. He's about the size of a 22-year-old, but he looks like a 9-year-old. No secondary sexual features, no hair. He has like zero testosterone and a lot of problems. The way they found this is he went into what's called an Addisonian crisis, which is can be life-threatening. It's due to no cortisol level or hormone. If you don't have cortisol hormone, your body doesn't deal with stress, and he almost died from that. Your blood pressure goes down, you have difficulty breathing. They diagnosed it, treated him, and then found the craniopharyngioma. So that's a typical presentation. Hormone problems, again, real location. Given your knowledge of neuroanatomy now, you can probably predict that you're supposed to have something running right through here, which controls vision, right? It's your optic nerves. So this patient probably is blind. And also hormone problems, blindness, and then when they get this big, they start affecting the brain's ability to get rid of the fluid. This is a fluid-filled space in here. It's starting to increase in size, starting to develop what we call hydrocephalus. And those are typical symptoms of craniopharyngioma. Also, it affects the hypothalamus, and this is probably as much or more of an issue post-treatment than it is pre. But when you damage the hypothalamus, that's where a lot of our regulatory centers are, our satiety centers. If we damage that, we have a tendency to eat and not feel satiated. So, and children that have this, they undergo treatment. Sometimes the parents have to lock the refrigerator. The kids will eat excessively. Also has a temperature regulation. Some of the blood pressure regulations is in that area. So you can imagine these patients will present with all those symptoms. Often weight gain. Okay, I'm sorry. Sure.
Many years ago, in 2003, I was diagnosed with a pituitary prolactinoma, and it was like 7/9 originally. Mm-hmm. And then, it went down somewhat a little bit since then. And then just as a freak, I wound up with stage 3C cervical and uterine cancer, right? And I had to have a total hysterectomy, but I was producing a lot of hormones at the time, and I had a thyroid problem also, hypothyroidism. After I had the hysterectomy, I don't know if this has anything to do with it, and that's why I was asking what the correlation was. My pituitary tumor went down to like almost 4 millimeters, 5 millimeters after. Was that because of all the hormone producing mechanisms from the hysterectomy? like produce all those hormones are gone now, so it made it shrink in size.
Did they remove the ovaries as well?
Everything.
Okay. It may have. There are feedback loops. You also have FSH and LH as well. And those are much harder to diagnose because of the cyclic nature of those hormones. We probably have functional pituitary adenomas that are FSH and LH producing. My theory in you, given that history, prolactin levels were 50-ish. Okay. Prolactinomas are difficult to diagnose when they're in the gray zone. The gray zone is minimally elevated. 30, some labs 30 is the top level of normal, some labs 40 is the top level of normal. When they're 50, 60, it's hard to know if this is a prolactinoma or not, to be perfectly honest. My theory, and it's not proven because it's difficult to prove it, is that perhaps some of the microadenomas we call non-functional actually produce abnormal levels of FSH or LH that affect the menses, affect the hormone levels, prolactin, and some of the other sex hormones, but are not technically a prolactinoma. Prolactinomas, it's hard to diagnose them unless they're up above at least 100 and typically 150 before we say this is definitely a prolactinoma. So maybe in your case, it was some type of FSH, LH producing. Once you remove the end organ, once you remove the feedback loop, then there's nothing feeding it and stimulating the production of those hormones, and so it has a tendency to shrink. And in fact, that's the mechanism of a prolactinoma. You're basically cutting off the feedback loop to the prolactinoma by the bromocryptine as a tendency to shrink. So it's, again, the hormone loops. Medicine just doesn't quite understand all the intricacies of how the different hormones feed back to each other. Okay. So that would be my theory. Okay. All right. So going with the craniopharyngioma. So those are the typical presentation. Now, what to do about it is much more complex, as you can imagine. So how do we get this thing out? Traditionally, it was a big craniotomy, take everything out. You need to get every last bit of it out. Now, that was good for decreasing recurrence rate, good for the look of the scan, not so good for the patients. As you can imagine, there are a lot. You have the optic nerve going through here. You have the nerves that go to the eyes and control eye function. You have the pituitary and all the pituitary hormones going through there. And you have the hypothalamus, which controls eating, it controls your blood pressure, controls your, basically the hemostasis, everything your body does to try to keep itself kind of within a certain range of blood pressure, of temperature, of eating. So the gross total resection, although it was a treatment of choice 20, 30 years ago, again, the patients didn't do so well postoperatively with that treatment. The tumor was gone, the scans looked good, the patients didn't look so good. So they flipped to the other side. Okay, let's just either leave these alone or treat them with radiation. Now, leaving alone is generally not an option because these tumors are progressive. They're somewhat relentless if you just leave them alone. And so that wasn't such a good idea either. So that was a bit of too much of a reaction the other way. The next treatment was radiation. Let's just blast these with radiation and hope for the best. The recurrence rates are too unacceptably high with radiation. You stop them from growing for a while, but then they have a tendency to come back. So the current approach is a radical debulking. So you go in, take everything out that's safe, and sometimes it's a bit of a fine line, what's safe and what's not. And then you treat it with radiation. They found out the recurrence rates with that type of treatment are nearly as good, in some cases better, than the gross total resection. Your morbidity, in other words, how you look after the operation, is much better. Patients don't have as much visual loss. They almost always have hormone problems. That's almost a given with the craniopharyngiomas. They will not have pituitary function. But the visual loss is much better. The brain injury was much better. These patients had a much better quality of life with radiation and surgical treatment. Again, what to expect after treatment? the main thing is the hormone problems with these type of tumors, hormone problems and vision problems. They will always be on some type of hormone replacement, and also fluid balance is always an issue. They have to take medications to keep their fluids in balance. The next type of tumor is called a chordoma, and again, it's going on real estate. This lady, and the reason I show these three first is basically the chordomas live in a similar area. This is the pituitary gland, and the chordoma lives basically in this area. And again, to slip a little bit of science in, it's actually from cells of the bone. It's the primitive notochord, which is basically the area that forms the spine. So it's basically those primitive cells that create the tumor. Again, a quote-unquote benign tumor, but often not so benign in the symptoms that it causes. This poor lady had 3 to 4 years of neck pain. She had this severe neck pain. She kept complaining of it. Nobody really took her seriously, got some x-rays, didn't really show much. Finally did an MRI scan, and she had this tumor going from basically here all the way down her spine. And it was ultimately turned out to be a chordoma. Chordomas, again, are benign type of tumors. They're relentless in their recurrence rate and their progression rate. And they typically present, classically, if you read the books, with a 6th nerve palsy. In other words, difficulty moving your eyes out to the side with some double vision. They can present with pituitary problems, but they usually don't grow up that high. It's the pituitary here. They usually don't grow up that high. It's usually the 6th nerve palsies, headache, and then when they start pressing on the brain here, that's when they start producing symptoms like imbalance. It can produce paralysis, weakness, and this is the brainstem here, if I get my cursor back. This is the brainstem here. Now the brainstem, as you may know, is basically the main connection between the brain and the spinal cord. Almost every function that your body does goes to the brainstem. So once you start pressing on the brainstem, it's usually bad news. It's, like I said, weakness, numbness, difficulties with eye movement, difficulties with balance. So often these patients will present with those symptoms, typically headaches, typically a 6th nerve palsy, and then just about anything with compression of the brainstem. Now, another point to go home with this type of these type of tumors is the treatment and the condition of a patient with this tumor is going to be very different than a patient with this tumor. This thing is massive, and it's starting to really press into the brainstem here. So these type of tumors, although they're the same pathology, what they expect and what they cause are very different type of issues. Again, unfortunately with the chordomas, there's really no magic bullet when it comes to treatment. There's no medications that really take care of it. The gold standard is surgery. Now, the ideal is to make the diagnosis early, surgery, do a gross total resection, and then followed by radiation. The unique thing about these tumors, they respond to, this is one of the few tumors that really respond to the proton beam radiation. Most of the other types of tumors, traditional radiation therapy versus the proton beam, there's not a big difference. But for whatever reason, the biology of these tumors really respond to the proton beam radiation. So ideally, you take them out, you get the patients to proton beam, even if you have everything out. In the large tumors, the recurrence rate is very high no matter what you do. And like I said, they're relentless in their biology and their recurrence. And the smaller tumors, and this is a patient that I saw, again, classically presented with bilateral 6th nerve palsy. She had difficulty looking mainly to the right versus the left. And these are pictures of her. Get back here. And I promise this is the only one I've done. A lot of surgeons get up there and they show you horrible pre-op scans and beautiful post-op scans. I'll do it once. so I get to brag once, but okay, so this is a chordoma all through here. Okay? This is the pituitary gland, the pituitary stalk. So this is a better view of the tumor, kind of off to the side. I believe is off mainly to the left side, producing mainly left-sided diplopia and movement of that eye. What we did was the minimally invasive approach to the nose, okay? And basically lifted up, found the pituitary gland, lifted it up, and then dissected this tumor off of the brain as we were lifting up the pituitary gland. And then post-op, although she was moving, it's a little bit grainy. Basically, the pituitary gland looks normal now. There's the dura covering the brain here, and really we got a nice gross total resection. She was in and out of the hospital in, I think, 3 days, 4 days. The point about this is that the traditional approaches to these tumors were big craniotomies, come from the side, and patients were sick for weeks and in rehab for a month or two. These newer approaches, we basically do a much more of a direct approach. It's not a big craniotomy. You're not pushing the brain out of the way. You're getting directly into the tumor, and that way you can remove the tumor without pushing on the brain and causing brain injury. And so this would have been traditionally an approach from the side, and again, it would have been a 12-hour operation. The patient would have been very sick for a week or two, probably in rehab for a month or two. She was at home in 3 or 4 days. So, okay, so what to expect post? It really depends, again, on the extent of the tumor. The large chordomas, it's impossible to get them all out. And so you're doing the proton beam, and unfortunately, the vast majority of the time, they will recur. The small chordomas, for instance, this type of chordoma, if you can get a gross total resection, you can get a proton beam using the radiation. Typically, it's a cure, and you have a very good long-term non-recurrence rate. Okay. Now, a couple more things, we'll get into the schwannoma. They don't put a clock up here, so I have no idea how I'm running on time. So maybe that's because Dr. Landolfi doesn't want to be reminded. So, okay, and what time should I be wrapping up?
I think we're running behind because lunch was at 11:55.
Okay, great, I'm standing between you and lunch. Sure, that makes me very popular. All right. Okay. All righty, so the fourth type of tumor is called the vestibular schwannoma. And again, it is a quote-unquote benign brain tumor, and it's hard to see on this scan because this little blip of white is actually the tumor. And these patients, it's the vestibular, it's also called acoustic. So you probably have heard acoustic neuroma, same tumor. Acoustic neuroma is actually a misnomer because it's not on the nerve, it's not on the acoustic nerve, that's a nerve for hearing, and it's not a neuroma, it's a schwannoma. So 20, 30 years ago, they had it completely backwards. It's actually on the vestibular nerve, and it's a schwannoma. It's more of medicalese what type of tumor type it is. Anyway, technically, they're called vestibular schwannomas. Classically, you'll have a patient come in with ringing in the ears. Tinnitus, I guess it's called on this coast. I'm from the West Coast. We call it tinnitus. But I've heard tinnitus. Either way, you come in with ringing in the ears. Often they have hearing loss as well. And they often don't notice it. You'll ask the patient, which side do you use a phone? They kind of look at you, well, why do you care? But yeah, I use it with my right side. And it's typically because you have a very subtle hearing loss on that other side. And so they switch sides of the phone, and they don't even notice it. When they think about it, it's like, oh yeah, you do it on the right. So classic symptoms of hearing loss and ringing in the ears. Typically, these are patients in their 40s and 50s, and I think there's a bit of a predominance of men. Whereas the chordomas, it's again 30s, 40s, 50s, and like I said, with the cranios, it's usually younger individuals. And not to insult anybody's age, I mean younger individuals, as in children, as in younger individuals, right? So now this, as like I said before, location, 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 and also size matters. This is a vestibular schwannoma as well. Okay? This is it here. And it's going into what we call the internal auditory canal. The internal auditory canal is the hole where the vestibular nerve goes, the acoustic nerve, and the facial nerve. So when the tumors get big, they start causing facial. At this size, I almost guarantee the patient does not have hearing. They probably have some balance issues, and they may start losing their facial function. They'll have a Bell's palsy of sorts. And And so you kind of imagine, again, this is the brainstem. These are the ears, the front of the brain, or front nose out here, back of the brain. This is a slice right like this. And so again, this is the brainstem. That's the very important structure. And this patient has bilateral acoustic neuromas. This is classic for a genetic condition called neurofibromatosis type 2. They have the bilateral acoustics. So what do we, and you can imagine that when you're pressing on the brainstem like this patient's going to have balance problems, they're going to be weak, they're going to have numbness, they're going to have a lot of problems other than just the hearing loss and the tinnitus. Now the reason I show you the extremes of the two, both of the same tumor, a little bit different treatment options, but again, it really, size matters, location matters. Okay? So what do you do about it? Now, this tumor, it really depends. Again, treatment options are the size matters. The small tumors that are not causing compressive symptoms do very, very well with gamma knife radiosurgery. It's an excellent control rate of the tumor, meaning growth rate at 10 years. And so generally, if it's less than 3 centimeters, you have to seriously consider gamma knife radiosurgery. So it's a one-time shot, it's radiation to it, and it stops the growth of the lesion. Now, in folks over 50 or 60, I think that's a great first option. Somebody that comes in and they're in their 30s, I'm not as convinced that this tumor is not going to grow in 15 or 20 years. So in those folks, I'll consider surgery. Once it gets beyond the 3 centimeters, and this, if you measure it out, it's going to be at least 3.5 or 4 centimeters. It has compression of the brain. Radiation is not going to be very good for this. First of all, it's too big. Secondly, it's right by this very important structure, the brainstem, and you'd really not want to injure this with radiation. So the treatment of choice for this patient would be surgery. Now, surgery, especially in the large tumors, it's pretty hard on folks. You come out, typically you have a lot of dizziness, a lot of imbalance, nausea and vomiting. Surgery is no picnic. And also the risk of facial nerve function and hearing loss is significant with surgery. And the small tumors, the loss of facial nerve function is about equal to surgery and gamma knife. It's really good. Once you get to the big tumors, you really start getting concerned about facial nerve function. Now, the facial nerve function doesn't seem like that big a deal. Okay, so your face is a little asymmetric. All right. And so most people say, okay, it's a cosmetic issue, not that big a deal. The more concerning issue is actually closing the eye. Because if you don't close the eye well, you can start developing damage to the eye, corneal abrasions, and people have lost their vision if not treated properly. So when I talk about facial nerve function, I'm less concerned about it just doesn't look nice. And I know that's an important part of it as well, so I'm not downplaying that. My main concern is the eye and the health of the eye. And with the large tumors, that's a big concern. So these patients, after treatment, the challenges these patients have, hearing loss, and loss of that facial nerve function. Okay, but now I just realized I made it sound like every patient's going to come out with horrible disfigurement. Now, that's not the case. And it really depends on the size of the tumor and what happens when you come in. If you have facial nerve palsy coming in, there is basically a 50-50 chance it's going to get better, actually. But there is maybe a 10% chance, depending on the surgeon, that things are going to get worse and you might lose it completely. If you have good function, again, it's depending on the size of the tumor. It's probably a 1 in 10 chance that you're going to completely lose the function. I tell patients there's a 50-50 chance things are going to get weak, but then you'll improve again. So actually, the majority of patients, if you come in and you have good function, 90% will have good function afterwards. Might take you some recovery, but you'll have good function in the large tumors. In the small tumors, it's better than that. But in the small tumors, almost all of them are going to gamma knife now. Also, when we're talking about treatment options, a patient with neurofibromatosis type 2, I don't think gamma knife is a good treatment for that. A lot of those have recurrence of the tumor. They grow right through the gamma knife. It's a different biology. And last but not least, and it's probably the most common one, the one you've heard of, are meningiomas. Now, these can occur anywhere around the brain. They're basically on the covering of the brain. They arise from the arachnoid cap cells, which is the scientific term of that covering. It's part of the meninges. And it can occur, this one is occurring right in the middle, okay? So it can occur right in the middle and grow out, compressing the brain. It can occur over here by the eye, compress the nerves to the eye. And it really, again, location, location, location. Where's it at is going to predict what it causes. Also, it's going to predict what the treatment options as well. Now, I included this because it was one of my patients that actually, she had headaches, and it was found because of that, but it was small, about a third of the size, and she was fine with it. We just watched it. However, she started developing this bump on her head. And she kind of thought it was a little horn growing. But so it was starting to develop here, and you could actually feel a little horn or a little bump growing. So these tumors will produce chemicals that cause hyperostosis and produce a thickening of the bone. And sometimes that causes problems. So if you think about it, all of these nerves that go through the skull go through holes in the bone. So if you cause a thickening of that bone, you can cause compression of those nerves. So that's called hyperostosis, and that's classic for a meningioma. So this is right by, again, one of the optic nerves comes right through here. A nerve that controls eye movement is right there. And it's a large tumor, okay? And so it's real, and it's starting to compress the brainstem as well. This patient presented with severe headaches, some visual loss, and double vision, difficulty moving the eye. The meningiomas, and again, how patients present really depends where it's at. So location, 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 and again, size matters. Small tumors are not going to produce noticeable symptoms. The big ones will, depending on location. The women are a little more prone to have these type of tumors, and typically it's in the fourth decade. The theory is that some of these tumors have estrogen receptors, and there's changes in estrogen often stimulate the growth of these tumors. Again, the treatment of choice for these type of tumors, in my opinion, anything over 3 centimeters is absolutely surgery. These are somewhat like the pituitary tumors that if you scanned 100 people, you'd probably find 4 or 5 have this type of tumor, don't even know it. So we find a lot of these for other reasons rather than we think they have a brain tumor. If they're small, then we don't do anything. We basically say, hey, let's just watch it, see what it does. Sometimes these things will be there for years, 10, 20 years without an issue. If they're larger and they're starting to cause problems, then that's when you have to think about treatment. Gamma knife, in my opinion, if it's surgical, gamma knife is a secondary treatment. You really should, if you can get these out, you're cured. If you can't get them out, then I often recommend radiation afterwards to treat whatever residual tumor you have to prevent it from recurring. Also, you can imagine if there was a small tumor and it was just down here compressing the brainstem, sometimes surgery is not the best idea because it's simply dangerous. And if it's a small tumor, it's at the skull base, then I think gamma knife or some type of radiation treatment is appropriate. What to expect really depends where it's at. On this tumor, it's the risk of the operation, the tumor is much bigger, the risk of operation is going to be bigger. That other patient, the risk of operation was much less than 1%. She's in and out of the hospital in 3 days, has some headaches post-op, but does very well. This patient came in with weakness on the right and did well post-op, but needed some rehabilitation. It wasn't an in-and-out deal. And again, location, 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 and size matters. Biology matters as well. You may hear of malignant meningiomas. They're rare. I won't get too much into the biology, but they are a cancer. There are the vast majority, 98%, are either grade 1 or grade 2s. They're benign tumors. The grade 2s have a tendency to come back, so if you can get them all out, they're cured. If you can't, then you really have to watch them. The grade 1s are purely benign. They have a low recurrence rate, and patients do very well with those. Okay? All right, so that's kind of my wrap-up for probably the 4 or 5 most common type of skull-base / benign tumors. probably 98% of patients who have a benign type of brain tumor that's extrinsic. I'm not talking about the ones that are from the cells inside the brain, but the 98% will have these type of tumors. And so hopefully it's giving you some insight into it. Take-home messages, location, 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 size matters, and the biology of the tumor does matter as well. A crania is going to act differently than a pituitary tumor. Okay?
I had a meningioma in the left frontal node in 1997. It was large, and it was removed surgically. After getting MRIs for a couple of years, I was told to go in 5 years. In 5 years, I didn't go because I was feeling great. And in the 6th year, I had a problem, and I had a recurrence, and it was again removed surgically.
Yes.
A few years after that, I got a small node in the center of the head, and that was removed with a stereotactic surgery. Now I have 2 nodes that are in the original area where the tumors were removed. They are stable so far.
Okay.
My question is, if they were to be removed, could I get the gamma knife or stereotactic surgery since it's not in the same location of where I had the other one?
Typically, yes. I guess it depends how close it is, because there is, gamma knife is very focused, but there is some cutoff of the radiation. So if it's far enough away, certainly, and far enough away is probably if it's more than a centimeter away from the original location, then it shouldn't be an issue.
Thank you.
Okay.
My sister just got diagnosed 2 weeks ago and just had the surgery last week for a frontal lobe meningioma.
Yes.
You were saying before, like, for this, is she still going to have, I mean, you were saying if you take it all out, it's cured. Is she, now we found out she's been having ringing in her ears for years and vision problems and everything else and massive headaches. Are those things going to, can we expect those things to go away now?
Well, I guess I'd have to see the scans to really give you a good educated guess on that. If it's, you said it's frontal lobe? Okay.
Yes.
Most likely, because most likely it's due to more of the just occupying the space, meaning it probably increased the pressure inside the brain that can cause severe headaches, can cause visual issues. And so the very fact that you removed that mass should mean that a lot of these symptoms will resolve. She'll probably still have a tendency to get headaches. Anyone's undergone a craniotomy, generally they have a higher tendency to get headaches. And cure versus not cure is really dependent on one grade. If it's a grade 1 and they got all of it out, then she's probably done. It doesn't mean that she doesn't need scans, because I always scan my patients 6 months, a year, yearly for 5 years, and then space them out after that.
Okay.
And usually by about 10 years, if there's no recurrence, you can usually assume that they're cured.
Thank you.
So. Now, sure. Realize each surgeon is going to be a little bit different. Your treatment routes are not set in stone. So the way we treat it is going to be slightly different than the way other people treat it. Don't misinterpret that as that we have different, one person's wrong, one person's right type of thing. It's still a bit of an art. Medicine's still a bit of an art. We have a lot of science behind it, but there's a lot of art behind it as well.
Hello, Dr. Steineke. I've heard many, many good things about you from a number of your patients.
Okay,
I was diagnosed with a benign brainstem glioma in 86. I was 11.
Okay.
So I've had many, many struggles, and through this, I've started a nonprofit that helps benign brain tumor survivors called It's Just Benign. So I think Landolfi might know of it. But presently, there are 600 people from the globe diagnosed with benign brain tumors. So I just wanted to, let everybody who's here, who's interested in connecting with other brain tumor survivors, to come see me. I can tell them more about. I can give them a brochure, or it's justbenign.org is the website. But again, I just wanted to tell you that I've heard many, many good things about you.
Oh, thank you. Really
You're
appreciate
welcome.
that. Don't interpret my focusing on more of the extrinsic tumors to say that the intrinsic tumors are not important. There are a number of intrinsic tumors that are benign, but they cause real problems. And although a lot of them we can take out surgically and present a cure, the patients still have struggles beyond the treatments. So. And those type of tumors is actually another hour talk at least. So, okay. All right, any other questions, or we're doing lunch? Okay, I don't want to keep you from lunch anymore. So thank you, and.